It now gives me great pleasure to introduce our second speaker. So Dr. Will Rattenberry is a new consultant anaesthetist. He's recently been appointed at Nottingham University Hospitals. He was the first author of the BJ Education article that you will see as an attachment on our RUK website and on this webinar, Spinal Anaesthesia for Ambulatory Surgery. And he's also worked alongside the Association of Anaesthetists to successfully campaign for the removal of plastic hook ring from the anaesthetic face masks. He's also, of interest to us, recently co-organised the Association of Anaesthetists online seminar on environmentally sustainable anaesthesia. Will, you're going to be talking to us about implementing a greener recovery with spinal anaesthesia. Over to you.
Thank you very much. Without further ado, I have absolutely no declarations to make, and the overview of the next 15 minutes is to talk briefly about the climate and environmental emergency, to focus our minds, revise the environmental impact of anaesthesia. I hope some, hopefully not all of it, the talk will be familiar to people, and specifically focusing on what are the benefits to the environment of spinal anaesthesia and ambulatory surgery. We live on a vulnerable planet of finite resource. This image of the Earth from the Apollo missions shows just how small our atmosphere is, with 80% of the gas in the first 10 kilometers. It is something which we're proving is extremely easy to pollute. We've known now since the late 1800s, thanks to a Swedish scientist called Arrhenius, that carbon dioxide can cause a greenhouse effect leading to global warming. And we know that current levels of 414 parts per million are unprecedented thanks to ice cores taken from Greenland and Antarctica. Temperatures are rising. We're already at 1 degree Celsius above the common baseline. To put that into context, the last ice age was only 5 to 8 degrees Celsius lower than that common baseline. The change is already apparent. 8 of the last 10 years, 8 of the last of the hottest years have occurred in the last decade. Wildfires are on the rise, as we've seen in Australia. Extremes of weather, such as Typhoon Haiyan, are more common, and this is in part thanks to warming oceans. And the ice is melting. This is an image of Greenland, where NASA have estimated almost 300 billion tons of ice is lost each year. But the environmental impact of what we are doing goes beyond just simply a warming planet. Air pollution, water pollution, plastic in the oceans, and loss of natural habitats and the effect on biodiversity is also ongoing. And as doctors and healthcare professionals, we are contributing to this. So what are we currently doing about it? In 2008, the UK government signed the UK Climate Act, which committed the UK to reduce our carbon emissions from 80% of the 1990 baseline by 2050. It quickly became apparent that this will not be enough to prevent serious and lasting damage. And the Paris Climate Agreement went further, committing governments to limit temperature rise to well below 2 degrees Celsius. The Lancet Countdown is an international collaboration which examines climate change and also looks at what governments are doing to tackle it. And their latest publication in 2019 said this: the life of every child born today will be profoundly affected by climate change, with populations around the world increasingly facing extremes of weather, food and water insecurity, changing patterns of infectious diseases, and a less certain future. Without accelerated intervention, this new era will come to define the health of people at every stage of their lives. As doctors, we have a responsibility to tackle it. In May of last year, the UK government went further to declare a climate emergency and has committed to net zero carbon emissions by 2050. COVID-19 has given us some insight into the scale of this change that is required. The lockdown, the effect on the economy and manufacturing, massive reductions in air travel has resulted in a reduction in global carbon emissions. But the highest forecast is a 13% reduction if lockdowns continue for the rest of the year. You can see from this that achieving net zero is a massive task. So how much does healthcare contribute? American healthcare is probably the greatest contributor to their national carbon emissions, accounting for about 10%, whereas in England, we know that it accounts for about 6.5% of our national emissions. This graph from 2018, the Sustainable Development Unit, looks at carbon emissions, and here on the right-hand side, we can see that anaesthetic gases contribute about 1.7% of our emissions, not only from the NHS, but also from social care. And this is roughly the same as the staff commuting of all 1.3 million NHS staff. We can see here that patient and visitor travel to hospital has massive carbon costs, and unsurprisingly, the supply chain of our equipment and pharmaceuticals are the largest contributors. So what are we doing about it in the NHS? The main document that talks about this is the NHS long-term plan, and it talks about a 2% reduction in NHS emissions by transforming anaesthetic practices. And I ask you, since January of last year, have you seen a transformation in the anaesthetic practices in your department because of environmental issues, and if so, why not? I suspect that everyone here is familiar with the fact that inhalational anaesthetic agents have a greenhouse effect, and that desflurane is the worst. This column here talks about the global warming potential over 100 years, with 1 being carbon dioxide. And we can see that desflurane is by far the worst gas from that point of view. Given that it has to be given in relatively high concentrations compared to sevoflurane and isoflurane to give a MAC of anaesthetic, the relative carbon dioxide production compared to sevoflurane is huge. We know from this paper by Vollmer et al. That these anaesthetic agents are detectable in the atmosphere and that they are on the rise. And we can see here the parts per trillion of desflurane is increasing, and this is in part due to the fact of its longevity in the atmosphere at about 14 years. So quickly, I'm just going to talk about calculating the environmental impact of general anaesthesia. I know many people have seen these calculators. There are 2 available. This is the environmental impact calculator created by Tom Pearce of the Royal College of Anaesthetists, and is also available online on the Association of Anaesthetists websites. We can do different calculations where we choose the second gas, whether that be nitrous or air. We choose whether we're going to do relatively high flows or low flow anaesthesia, and we can calculate the cost and then the carbon dioxide. And we can see this staggering amount of carbon dioxide, 117 kilograms per hour, when using desflurane at this relatively steady state, not incorporating priming of the anaesthetic circuit or the initial washing. Sevoflurane and isoflurane are better. If we get rid of the nitrous, which we know is bad for the environment, and replace that with air, reduce the flows to below 1, which would be by most people considered a low flow anaesthesia, there are significant improvements, and sevoflurane starts to get down towards the 1 kilogram of CO2 per hour. If we go ultra low flow, which is my typical practice at steady state, but is not done in many countries, including America, where they have thresholds for this, we can see that there are some further carbon dioxide benefits, particularly with desflurane, having said that the benefit with sevoflurane is much less. 31 kilos of carbon dioxide is roughly equivalent to 100 kilometers in a modern car, and sevoflurane 1 kilo would be roughly equivalent to 3 or 4 kilometers in a car per hour. How about TIVA? Lots of people now are talking about the environmental benefits, but how green is it? This is the main landmark study by Jody Sherman at Yale and colleagues, looking at the different agents and calculating their greenhouse gas emissions throughout the entire life cycle. The top plot looks at the entire greenhouse gas effect and demonstrates that it is not manufacture, but the release of the agent into the atmosphere that causes the greatest damage. The plot below then compares the 4 drugs, excluding that agent release. And so we could imagine that this is a situation where we've got some gas capture technology where actually we release none of the inhalational agent into the atmosphere. And we can still see that there are major benefits with propofol. Spinal anaesthesia. So trying to calculate the environmental cost of spinal anaesthesia is not straightforward. life cycle analysis of drugs in terms of their carbon expenditure is not routinely performed. However, the Gas and Greener app does allow us to do this for a sort of fairly traditional spinal anesthetic using lidocaine for the skin and intrathecal bupivacaine, and we see that the amount of the kilogram of carbon dioxide to do this is calculated as extremely low, negligible, one might argue. How do we know this? Again, we know this by work from Jody Sherman and colleagues. This paper from Parvatka et al. Published last year performed a life cycle analysis. They call it cradle to gate. In the UK, it'd be more common to say cradle to grave, I guess. But the greenhouse gas emissions of 20 commonly used anaesthetic drugs. And we can see the scale here is actually logarithmic. It's not linear. 100 here, 1,000 kilograms per kilogram of drug, so quite a lot of drug. We can see propofols are actually low down, bupivacaine and lidocaine are relatively low down. What was a surprise to me is morphine, which I thought of as a fairly natural drug from poppies, is actually 1,000. Moving on to the drugs that we're particularly focusing on today, the short-acting local anaesthetic agents. We don't know the exact carbon dioxide cost of these drugs, but it'd be reasonable to assume that they're similar. And Synthetica informed me that their manufacturing plant is 100% renewable energy, and these sorts of things need to be factored in. Every drug has an environmental risk assessment before it is marketed, and we know from this that prilocaine doesn't bioaccumulate, and that whilst it has aquatic toxicity at much higher doses, which is seen with many, perhaps most drugs when they put them in the water with fish, that the European Medicines Agency determined that it's an insignificant risk to the environment because the predicted concentration in the water course is so far below that toxic level. 2-chloroprocaine, on the other hand, has got such a predicted low environmental concentration level and low risk of bioaccumulation that it wasn't even required that they did any aquatic toxicology studies with the 1% preparation. But I understand with the aim to use 2% with peripheral nerve blocks that those studies are being undertaken. So what are the other benefits of spinal anaesthetics? We've all done spinals and general anaesthetics, and they tend to use less resource, particularly airway equipment, and this results in less waste. We've heard from Professor Howard Griffiths how there's a benefit to use less PPE, and even in institutions now that are using reusable respirators, that tends to mean gloves and gowns not being thrown away. I've written here lower risk of aquatic toxicity than propofol, and we could argue that there is no risk of aquatic toxicity with local anaesthetic agents. It's certainly extremely low. And with propofol, it's important to say that the study there does say it's a low risk of aquatic toxicity, and that not only looks at propofol, but assumes that all of its metabolites are also potentially toxic to fish. So what should we mean by transforming anaesthetic practices? I think this means RA wherever, regional anaesthesia wherever possible, wherever it is a clinically sound decision and the patient consents to this. It means that when we do general anaesthesia, it's reasonable to avoid desflurane and nitrous oxide. We should always use low-flow closed-circuit anaesthesia with our volatile agents, and where possible, TIVA is almost certainly the greener choice. Spinal anaesthesia can help us facilitate ambulatory surgery. There are patients that are high risk for day case general anaesthesia, perhaps somebody with moderate to severe respiratory disease, who can safely be done in a day surgery environment with a short-acting spinal. It can improve theatre efficiency and patient flow. It can allow patients who choose not to have sedation to engage with their therapy, and this may reduce the need for outpatient follow-up and the journeys involved with that. We know from a study from Gebhardt and colleagues in 2018 that spinal anaesthesia is approximately half the cost of TIVA, day case anaesthetic. It's important that we just take a moment to think about what the benefits are of the environmental benefits of ambulatory surgery. And whilst these haven't been quantified, there are some fairly obvious ones. We know that there are fewer on-the-day cancellations, that's wasted patient journeys. We know that there are reduced complications of thromboembolism and hospital-acquired infections. Complications require resources and they have a carbon cost. We know that if you're at home, people don't need to travel long distances to see you, and we saw from that earlier graph that travel is a significant carbon cost within the National Health Service. And we know that ambulatory surgery can improve efficiency and have overall reductions in cost. And it's reasonable to assume that these are associated with reduced carbon emissions. COVID-19 gives us a significant opportunity. Spinal anaesthesia has major benefits for both, and keeping people out of hospital and having procedures in our day units or ambulatory surgery units is certainly a benefit. And I think this is a golden opportunity with all of the upheaval and change to pathways to redesign pathways and reconsider the local status quos, just like Professor Harold Griffiths' colleague. The environmental benefits can be scaled up significantly when we do this in the thousands. This paper from just last month, entitled Green Journal, looks at the benefits of doing thousands of hip and knee arthroplasties under spinal as opposed to the US norm of under general anaesthesia. And the benefits are enormous. So my conclusions are that spinal anaesthesia is green, ambulatory surgery is desirable from an environmental point of view, and COVID-19 provides us an opportunity to change our established practice. Thanks for listening.
Will, thank you very much for a very enlightening talk. Not surprisingly, I've got a large number of questions that are coming through here. First question, which I think is probably relevant, is what is your definition of ultra low flow?
I'm not sure there's a consensus definition, but I did look that up, and less than 1 litre low flow, less than 0.5 litre ultra low flow, I think it's a fairly non-scientific, not a consensus, but it has been documented in the literature before.
Perfect, thank you. Another question, with TIVA, is there any information about all the plastics that's used and disposed of with regards to that environmental impact and how that compares with, say, other forms of anaesthesia?
So within that analysis by Jodie Sherman, she looked at the carbon cost of not only procuring, supplying the plastics, but also incinerating those plastics. So that is included within that carbon cost. I suppose there are potentially things which are not included. So the damage to the environment from particulate matter due to incinerating that additional waste would not be included. So we need to look beyond just simple carbon costs. And we know that when we make PVC and plastics, we use plasticizers, potentially dioxins, other harmful chemicals. So in terms of the carbon cost, yes, it has been factored in, and it is still an order of four orders of magnitude better. So it's still enormously better. But it's fair to say that some of the other environmental costs have not been factored in.
Okay. Another question, Will. Should we be discussing the environmental impact of our technique with our patients, and will this become part of informed consent?
So I think the answer to that question is similar to the professor's answer earlier. I think if the patient is considering both options, wants to know everything about it, it's reasonable to discuss the environmental impact. I think that we're in a fortunate position whether you're considering TIVA versus inhalational anesthesia or ambulatory spinals versus generals, that often that information is not relevant. We're not offering an inferior technique, and in many ways we may be offering a superior technique. But I do imagine that as the climate emergency becomes more emergent, that it becomes a bigger agenda, that people will be asking these questions. I think it's the Centre for Sustainable Healthcare are now talking about us considering the triple bottom line. We're all used to our hospitals saying, you know what, we're not going to provide that drug for you, or we might restrict your access to, let's say, Sugamadex because it's very expensive. We're not used to anybody saying we might restrict your access to that drug or that technique because it is very environmentally damaging. And I think that is going to happen over time. At the moment, it's certainly not my practice to say I'm offering this technique because of any environmental impact. I'm offering the best technique for the patient and then looking at how I can mitigate the impact of that technique.
And the final question, so we don't overrun, is how do you convince your colleagues not to use TCI sedation with regional anaesthesia, or should we be convincing our colleagues not to use sedation with regional anaesthesia?
I think Robbie Erskine will probably have an excellent answer for that in a minute. I think I wouldn't want to put people off making the transition, certainly from an environmental point of view, of if people feel happier whilst they're trying to use spinal techniques for unfamiliar procedures, utilizing sedation. I think experts like Robbie will tell you that that is perhaps not required. And I think that from with regards to the topic, the content of my talk, From an environmental point of view, yes, that will have an environmental cost, but a small amount of midazolam or TIVA TCI, the environmental costs are relatively insignificant compared to the other.
Will, thank you very much for a really enlightening talk.